Good morning. Greetings from NITEP, e-NEETI, Nurses' Efforts to Eliminate TB in India. I am Shima John, moderator for today's e-NEETI, and we are thrilled to have you here for the session NTEP Updates. Before we dive in, I would like to give you all a brief overview of what we have planned today. We will start with the presentation by a presenter, followed by a question and answer session. We encourage you to participate actively. Feel free to ask questions and share your thoughts by writing in chat box. Your thoughts and questions are invaluable for us. I hope our e-NEETI with chain of sessions will help you grow and become more productive as well as smarter than your present capacity. A quick note on technicalities before we start. Please, I request all of you to keep your microphones muted so there is no background noise disturbances. If you experience any technical issues, let us know in the chat and we'll surely prompt you as soon as possible. I request all of you to join separately and not in groups so that otherwise, if you join in groups, you won't be able to avail your certificates. If you really need your certificate, you have to join separately through your own phone number or through email IDs. This is our 22nd e-NEETI clinic and we conduct this on third Friday of every month, but due to some problems, we are doing this on the second Friday. Now, we have already covered many topics on TB and chest diseases. We have covered MDR TB, asthma, infection control, infection group practices like ventricular associated events. Now we are excited to get started and look forward to productive and enjoyable session together. Thank you again for being here. Let's begin with the welcome remarks by our Nursing Superintendent, Dr. Anita Rani Kansal ma'am. Ma'am is also a chairperson of CNE Cell. She has been a master trainer for training of nurses in TB by International Council of Nurses. International Council of Nurses has also conferred her with Leading Light Award. She has been trained in airborne infection control by CDC. Welcome you, ma'am, to this clinic. Please kindly share your welcome story.
Thank you, Shima. Good afternoon, everybody. First of all, I would like to welcome our DDG TB, Madam Dr. Urvashi, and would like to thank her that she has spared some time to motivate our nurses and to address them in this e-NEETI session. And I welcome our director, Ma'am Dr. Manpreet Bhalla, also. And I welcome Dr. Neeta Singla, who is DTO and she's the nodal officer for Echo Clinic also. And she's always there for us whenever we need in the TV trainings or in Echo sessions. So today's topic for the discussion is NTPE, National Tuberculosis Elimination Program update. And this session is very important because there are so many new guidelines and new things that will be coming, and usually the nurses, whether they are nursing students or the nurses working in the even the TB institutions, they are not aware of these new guidelines because they are not being circulated to the principals of colleges or the nursing superintendents. So whatever they learn from their practical experience, they'll come to know. And with these e-NEETI sessions, we would like to circulate these new guidelines or new things, whatever is coming in the TB control program by this today's session. And this is just my request that if we can circulate, if the principals of nursing colleges or the nursing heads of TB institutions, they are also in the loop of dissemination information or guidelines by the CTV, then it will be better so that they can communicate to their students or to their nurses, and ultimately this can reach to the consumers or the patients or in the because they're working in communities as well as in hospitals. So with this, I welcome you who have joined and Bima for further.
Thank you. I request Dr. Manpreet Bhalla ma'am, Director of Institute NITRE, to share her thoughts on e-NEETI classes. But we are open to any message you feel would be impactful. Your presence greatly enhanced the value of our class, ma'am. Can you hear us, ma'am?
Yes, am I audible?
Yes, ma'am.
Yeah, thank you, Shima, and good afternoon, everyone. And again, I want to wish to thank DDG TB Dr. Urvashi for joining today's session, which is on nurses' efforts to eliminate TB in India. And today's session, as Dr. Neeta Madam has said, it is on NTEP update. So I just want to say that nurses are a very important part in the TB elimination program, and they play a very important role. I think without the nurses, it will be very difficult for us to achieve this goal. And also today's topic is on NTEP, and will the latest guidelines will be discussed. Dr. Neeta, who's the nodal officer for DRTB, she is present today as an expert, so she will be able to answer all queries related to the latest guidelines and all the campaigns and programs which are going on. The 100 days campaign as well as other programs for the elimination of TB till March 2025. So thank you, and please continue with the session. I look forward to the deliberations. Thank you.
Thank you, ma'am. Thank you for setting the tone for today's session and for your inspiring words. It is our distinct honor to have with us Dr. Professor Urvashi B. Singh, DDGTB, CTB. Ma'am, we are eager to gain from you valuable insights and perspectives. Before we delve into our session, a subject of paramount importance in our ongoing efforts to NTB, I request ma'am to please address and share her thoughts. Ma'am, are you there? Are you audible?
Good afternoon,
Hello,
all.
ma'am.
Am
Good
I
afternoon,
audible?
ma'am.
So at the outset, let me thank NITRD, Director NITRD, Dr. Neeta Singla, the the nursing staff, Madam Consul. It is an honor to be here, but more than that, I am amazed to see the initiative taken by the nurses at NITRD to initiate such a session. Of course, the guidance of the director and Dr. Neeta Singla must have been there, but I really congratulate you for this effort and a possible gain that all the members who have joined here today for the session. It'll be continuing medical education for them, and I would encourage you to do more such events. Coming on to the role of nurses in care for all medical care, or especially in TB, I would say it is a selfless effort that all of you put in serving the patients, especially the TB patients, where the transmission would happen through air, and not all hospitals, not all centers are trained or equipped with airborne infection control practices. We have been, working on airborne infection control under the program, and in fact, making it, trying to make it mandatory for all centers, all medical colleges, all hospitals where TB patients are to be admitted, or even in the OPD, to ensure that airborne infection control guidelines are in place. That effort has been going on in the program for the past more than 14 years now, and we are in fact about to launch a new guideline. But what I must, actually commend and congratulate the nurses for is their determination to serve such patients despite the risk involved and despite the facilities not being optimum all over. So we will continue to strengthen you all further, and this training that has been organized today, I would say, should go on in the long term. You can have, like Dr. Neeta organizes regular activities for difficult to treat TB clinic, or like Dr. Sangeeta has been leading the difficult to treat pediatric TB clinic. So this effort possibly can go on, and the encouragement, not only the encouragement and the guidelines that this way the program guidelines will get disseminated. It will be a training activity which will strengthen all the attendees, the knowledge of the guideline and the changes that we are bringing in. In fact, we are moving very fast. So there are new changes coming in every now and then based on the clinical evidence available globally. We like to walk with the global evidence and we keep bringing in changes. So I think this activity is very welcome, and I wish you all the luck today and going forward. Kindly try to keep this a continuous activity. So, with a big thank you and looking forward to what the discussions would be for today. Thank you again.
Thank you, ma'am. Thank you for your guidance and motivation. Your presence is a source of inspiration for us all. Thank you once again, ma'am.
I just want to convey, ma'am, thank you. As you said, the airborne infection control is very important. Our next webinar will be a mega webinar on the World TB Day. It will be on 21st of March, and three speakers, one from the Nagpur and two from the NITRD will be speaking on this, and it will be 2 hours webinar. I will request, ma'am, for your presence on that day also. I will be requesting you on the email and on the WhatsApp, and ma'am Neeta will be coordinating. Thank you so much, ma'am, for this.
Now, moving on to the presenter and the expert. To my right is Miss Indu. She's going to present on NTEP. She's been here since it's been 1 year. She's here. Previously, she was working as a nursing officer in AIMS Bhubaneswar. So we welcome you all, Miss.
Thank you.
Now, to my extreme right is Dr. Neeta Singla, ma'am. She is an expert today for our topic NTEP. Ma'am is Nodal Officer for DRTB Center and DRTB Eco Clinic NITRD. We welcome you, ma'am. Thank you for accepting. Now, I request Ms. Indu to proceed with her session.
Thank you, ma'am. Good afternoon, everyone. I am Bindu Singh and I am going to present a topic on National Tuberculosis Elimination Program. जैसा इस टॉपिक का नाम है ट्यूबरक्लोसिस एलिमिनेशन, तो हम एक ब्रीफ डिस्कशन करेंगे टीबी के बारे में. व्हाट इज टीबी? तो टीबी इज एन एयरबॉर्न इन्फेक्शियस डिजीज विच इज कॉज्ड बाय माइक्रोबैक्टीरियम ट्यूबरक्लोसिस. एयरबॉर्न इन्फेक्शियस मींस जिसमें ड्रॉपलेट न्यूक्लियाई का साइज लेस देन 5 माइक्रोन है, तो स्मॉल इन साइज है, तो वो लॉन्ग डिस्टेंस तक स्प्रेड होता है एंड लॉन्ग टाइम तक एयर में सस्पेंडेड रहता है, इसलिए ये मोस्ट इन्फेक्शियस डिजीज है विच इज ट्रांसमिटेड थ्रू स्नीजिंग, कफिंग एंड स्पीकिंग. यदि हम पर न्यूक्लियाई काउंट का बात करते हैं पर कफ, तो ये 3000 इन्फेक्शियस न्यूक्लियाई पर कफ प्रेजेंट होता है. टीबी बर्डन की यदि हम बात करते हैं तो इंडिया इज हाईली टीबी बर्डन कंट्री इन द वर्ल्ड. यदि हम कंपैरिजन करते हैं ग्लोबल वर्सेस इंडिया का चार्ट हम देखते हैं तो टोटल का 26% जो कंट्रीब्यूशन है वो इंडिया का है इंसिडेंस ऑफ टीबी केसेस. ऐसे मॉर्टेलिटी ऑफ टीबी केसेस की यदि हम बात करते हैं तो टोटल का 29% जो केसेस है वो प्रेजेंट होते हैं इंडिया के अंदर. एंड एमडीआर टीबी का यदि हम बात करते हैं तो टोटल का 27% कंट्रीब्यूशन इंडिया का है फॉर एमडीआर टीबी में. देन नेक्स्ट, इवोल्यूशन ऑफ टीबी एलिमिनेशन प्रोग्राम. टीबी एलिमिनेशन प्रोग्राम का जो यदि हम स्टार्टिंग से इवोल्यूशन देखते हैं तो टीबी से रिलेटेड जो फर्स्ट प्रोग्राम आया था वो था नेशनल ट्यूबरक्लोसिस कंट्रोल प्रोग्राम इन 1962. देन इसके बाद इसको अपग्रेड कर दिया गया 1997 में, एनटीसीपी को कन्वर्ट किया आरएनटीसीपी में, जिसके अंदर डॉट स्ट्रेटेजी को ऐड किया गया. देन फर्दर इसमें और इम्प्रूवमेंट हुआ 2007 में, टीबी प्लस एचआईवी कोलाबोरेशन ऐड हुआ. देन उसके बाद 2016 में एफडीसी फिक्स डोज कॉम्बिनेशन ड्रग्स ऐड हुए फॉर डीएसटीबी ड्रग सेंसिटिव टीबी के लिए. 2017 में जो एमडीआर टीबी का जो ट्रीटमेंट है उसके अंदर बिडाकुलिन को ऐड कर दिया गया. देन 2020 के अंदर आरएनटीसीपी का रीनेम हुआ एनटीईपी, नेशनल ट्यूबरक्लोसिस एलिमिनेशन प्रोग्राम, विच अलाइन विद एसडीजी सस्टेनेबल डेवलपमेंट गोल टारगेट के साथ में. तो हम नेशनल टीबी एलिमिनेशन प्रोग्राम के बारे में डिस्कस करते हैं. तो जैसा हमने पढ़ा 2020 के अंदर आरएनटीसीपी रीनेम हुआ एनटीईपी के अंदर. जो मेन इसके अंदर हमारा जो एम था कि एलिमिनेशन ऑफ टीबी इन इंडिया बाय 2025, जो ग्लोबली टारगेट है वो है 2030 तक एलिमिनेशन ऑफ टीबी इन वर्ल्ड. लेकिन हमारा 5 ईयर अहेड है कि इंडिया में 2025 तक हमें टीबी को एलिमिनेट कर देना है. और ये हम कैसे एलिमिनेट करेंगे? बाय प्रोवाइडिंग वेरियस फ्री ऑफ कॉस्ट क्वालिटी ट्यूबरक्लोसिस डायग्नोसिस एंड ट्रीटमेंट सर्विसेज. फ्री ऑफ कॉस्ट डायग्नोसिस एंड ट्रीटमेंट सर्विसेज प्रोवाइड करके एलिमिनेट करना है टीबी को बाय 2025. देन इसके लिए जो हमारा एसडीजी टारगेट है ग्लोबली 2030 तक का टारगेट है और इंडिया के अंदर 2025 तक का ये हमारा टारगेट है कि 90% रिडक्शन करना है इन टीबी मॉर्टेलिटी, जो डेथ रेट है उसको हमें 90% तक रिड्यूस करना है, जो इंसिडेंस रेट है उसे हमें 80% तक रिड्यूस करना है, एंड जो कैटास्ट्रॉफिक कॉस्ट है उसे हमें 0% करना है। कैटास्ट्रॉफिक कॉस्ट मतलब जो भी ये डिजीज है इससे रिलेटेड जो भी डायग्नोसिस है, ट्रीटमेंट है, वो हमें बिल्कुल फ्री ऑफ कॉस्ट करना है, ताकि जो टीबी अफेक्टेड फैमिलीज है उस पर कैसा भी इकोनॉमिकली बर्डन ना हो। ये हमारा टारगेट है। इस टारगेट को अचीव करने के लिए एक नेशनल स्ट्रेटेजिक प्लान बनाया गया फ्रॉम 2017 टू 2025। इसके अंदर हमारे 4 इंपॉर्टेंट पिलर है। फर्स्ट इज डिटेक्ट, सेकंड ट्रीट, थर्ड प्रिवेंट एंड फोर्थ बिल्ड। डिटेक्ट मीन्स अर्ली डायग्नोसिस और फाइंड आउट ऑल टीबी केसेस। देन ट्रीट, इसमें ऑल टीबी केसेस ट्रीट विद हाई क्वालिटी टीबी ड्रग्स। देन प्रिवेंट, जो मेन ससेप्टेबल पॉपुलेशन है जो कि मोर प्रोन है टू गेट टीबी इन्फेक्शन, उन्हें हमें प्रिवेंट करना है फ्रॉम लेटेंट टू एक्टिव टीबी ट्रांसमिशन के लिए। एंड स्टॉप कैटास्ट्रॉफिक एक्सपेंडिचर, जो हमने भी देखा, जो फाइनेंशियल बर्डन है वो जीरो करना है। एंड फोर्थ हमारा पिलर बिल्ड, बिल्ड एंड स्ट्रेंथन सपोर्टिव सिस्टम। सपोर्टिव सिस्टम जिसमें पॉलिसीज, इंस्टीट्यूट, ह्यूमन रिसोर्सेज, वो हमें इतना स्ट्रांग बनाना है जो कि हेल्प कर सके टीबी पेशेंट्स को। देन वन बाय वन हम इसको डिस्कस करें तो डिटेक्ट के अंदर जैसे कि टीबी स्क्रीनिंग टू आयुष्मान आरोग्य मंदिर, जिसके अंदर जो सब सेंटर्स है, पीएचसी सेंटर्स है, उन्हें हमें इतना हाईली अपग्रेड करना है फॉर डिटेक्शन ऑफ टीबी। इसके अलावा मॉलिक्यूलर डायग्नोस्टिक ऑफ पेरिफेरल लेवल, इसमें मॉलिक्यूलर एक टेस्ट आता है नाट करके, न्यूक्लिक एसिड एम्प्लीफिकेशन टेस्ट, जो कि यूज में लिया जाता है फॉर टीबी डिटेक्शन। अर्ली डिटेक्शन ऑफ डीआरटीबी एंड डीएसटी है। वल्नरेबल मैपिंग एंड एक्टिव केस फाइंडिंग, ऐसे पेशेंट जो कि बहुत रिमोट एरियाज के अंदर है, उन्हें जैसे मोबाइल मेडिकल वेन के थ्रू उन रिमोट एरियाज में जाना और उन केसेस को अर्ली डिटेक्ट करना। देन इसके अलावा प्राइवेट सेक्टर, गवर्नमेंट के साथ में जो प्राइवेट सेक्टर है वो भी इसमें इन्वॉल्व हो। फॉर एग्जाम्पल यहाँ पर लिखा है जीत, जीत मीन्स ज्वाइंट एफर्ट फॉर एलिमिनेशन ऑफ टीबी करके एक सपोर्ट एजेंसी है जो कि इसमें हेल्प करती है। देन डिटेक्ट के लिए एक न्यू जनरेशन टेस्ट भी है जिसको हम साई टीबी कहते हैं। ये जो मॉन्टेक्स टेस्ट है उसका ही एक अपग्रेड फॉर्म है जो कि सीरम इंस्टीट्यूट ऑफ इंडिया के थ्रू बनाया गया है, जो कि लेटेंट टीबी डिटेक्शन के लिए यूज में लिया जाता है। साई टीबी के अंदर 1:1 रेशियो में टू रिकॉम्बिनेंट प्रोटीन्स प्रेजेंट होते हैं, ESAT6 एंड CFP10। जैसे कि मॉन्टेक्स टेस्ट के अंदर हम इंट्राडर्मल इंजेक्शन, वहां पे भी वही इंट्राडर्मल रूट के थ्रू हम इंजेक्शन मतलब ये इंजेक्शन एडमिनिस्टर करते हैं। देन 72 आवर्स के बाद में जब हम रीडिंग देखते हैं तो मोर देन यदि 5 mm का इंड्यूरेशन है, मीन्स उसको हम पॉजिटिव मानते हैं वो लेटेंट इन्फेक्शन के लिए। देन सेकेंड हमारा इसमें पिलर आ जाता है ट्रीट के अंदर, जैसे कि आजकल हमारे जो डोजेज हैं जिसको हम कहते हैं FDC, एक फिक्स डोज कॉम्बिनेशन होता है जिसमें सारे फर्स्ट लाइन टीबी ड्रग्स प्रेजेंट होते हैं, तो FDC फॉर्म में होता है। इसके अलावा सस्टेन ट्रीटमेंट, जो सक्सेस रेट है, बहुत से ऐसे पेशेंट हैं जो कि ट्रीटमेंट स्टार्ट कर देते हैं लेकिन पूरा कोर्स कंप्लीट नहीं करते हैं, तो मेन हमारा इसमें टारगेट है कि मोर देन 90% तो ऐसे केसेस हो जो पूरा ट्रीटमेंट कोर्स कंप्लीट करें। इसके अलावा इंजेक्शन फ्री ट्रीटमेंट रेजिमेन, टीबी एक ऐसा डिजीज है जिसके ट्रीटमेंट में मोस्ट ऑफ सब मेडिसिन है, तो इंजेक्शन का ऐसा नहीं है, तो मेडिसिन इजीली लोग अपने घर पर भी ले सकते हैं। इसके अलावा स्केल अप ऑफ न्यूअर ड्रग्स एंड रेजिमेन, जैसे कि बीडाक्यूलिन, डायलेमाइड करके न्यू ड्रग्स फॉर MDR ट्रीटमेंट के लिए इसमें ऐड हुए हैं। यदि हम थोड़ा डिटेल देखते हैं मेडिकल मैनेजमेंट के बारे में, तो फर्स्ट लाइन जो एंटी टीबी ड्रग्स है जिसके अंदर 4 ड्रग्स आता है, रिफेम्सिन है, आइसोनियाजाइड है, पायराजिनेमाइड है, इथेम्ब्यूटॉल है। हम डीएसटीबी मीन्स ऐसे पेशेंट जो इन फर्स्ट लाइन ड्रग्स के लिए सेंसिटिव है, मीन्स ये ड्रग उनके लिए काम करती है, उसके लिए हमारा 6 मंथ का कोर्स होता है जिसमें 2 मंथ है इंटेंसिव फेज, जिसके अंदर हम 4FDC मीन्स आइसोनियाजाइड, रिफेम्सिन, पायराजिनामाइड एंड इथेम्ब्यूटॉल का 2 मंथ का कोर्स देते हैं। देन उसके बाद में 4 मंथ का आता है, उसे हम कहते हैं कंटिन्यूअस फेज, जो कि 18 वीक के लिए होता है, जिसमें 3 ड्रग्स आएंगी, आइसोनियाजाइड, रिफेम्सिन एंड इथेम्ब्यूटॉल। इन केस ऑफ CNS टीबी, स्केलेटल टीबी या डिसेमिनेटेड कोच में ये जो कंटिन्यूएशन फेज वाला ट्रीटमेंट है ये अप टू 24 वीक्स तक हो सकता है। देन उसके बाद में जैसा हमने देखा एफडीसी, एफडीसी में 4 एफडीसी भी आता है, 3 एफडीसी भी आता है। तो कितने नंबर, कितना काउंट, नंबर ऑफ टैबलेट्स इसकी होंगी, ये डिपेंड करता है बॉडी वेट पर। वेट के अकॉर्डिंग हम मिनिमम 2 एंड मैक्सिमम 6 टैबलेट्स तक इंटेंसिव एंड कंटिन्यूएशन फेज में देते हैं। देन उसके अलावा एक एच मोनो आइसोनियाजाइड मोनो करके टीबी होता है, जिसके अंदर 6 मंथ का हम लिवोफ्लोक्सासिन, रिफेम्सिन, पैराजिनामाइड एंड इथैम्बुटोल ट्रीटमेंट देते हैं। यदि हम एमडीआर मल्टी ड्रग रेसिस्टेंट टीबी की बात करते हैं तो इसके 2 है, एक तो शॉर्ट ट्रीटमेंट है, एक ओरल ट्रीटमेंट, एक लॉन्गर ट्रीटमेंट है। शॉर्ट ट्रीटमेंट जो कि 6 मंथ के लिए सब ड्रग्स आ जाता है, लिवोफ्लोक्स, क्लोफा, पैराजिनामाइड, इथैम्बुटोल, हाइडोज आइसोनियाजाइड, इथ्योरेमाइड एंड बिडाकुलिन। एंड 5 मंथ के लिए 4 ड्रग्स है, लिवो, क्लोफा, पैराजिनामाइड एंड इथैम्बुटोल। देन ओरल जो लॉन्गर ट्रीटमेंट है उसमें एमडीआर एंड एक्सडीआर टीबी रेजिमेन आ जाता है, जो 18 टू 20 मंथ तक एक्सटेंड होता है, जिसके अंदर बिडाक्यूलिन है, लिनोजिनाइड, लिनोजोलिड है, लिवोफ्लॉक्स है, क्लोफाजिमिन है एंड साइक्लोसेरिन है। तो ये इसके अलावा एक न्यू रेजिमेन और यूज में लिया जाता है जिसे हम कहते हैं बी पाल्म रेजिमेन, जो एक रिसेंटली इंट्रोड्यूस रेजिमेन है, जो मोर सेफर एंड मोर इफेक्टिव ट्रीटमेंट मानते हैं कंपेयर टू ट्रेडिशनल एमडीआर टीबी, जिसके अंदर 4 ड्रग्स आते हैं, जैसा कि इसका नाम है बी पाल्म। बी मीन्स बिडाक्यूलिन, पी ए मीन्स प्रीटोमैनेट, एल मीन्स लिनिजोलिड एंड एम मीन्स मॉक्सीफ्लॉक्सासिन। ये 4 ड्रग्स इसमें यूज में लिया जाता है। देन इसका यदि हम देखते हैं तो 14 ईयर्स, मोर देन 14 ईयर्स के लिए ये बी पाल्म रेजिमेन यूज में लिया जाता है, जिसके लिए बिडाकुलिन 400 mg वंस डेली फॉर 2 वीक्स 14 डेज के लिए। देन उसके बाद में 200 mg 3 टाइम्स पर वीक, जैसे मंडे, वेडनेसडे, फ्राइडे, ऐसे 3 टाइम्स पर वीक देते हैं। और 200 mg डेली फॉर 8 वीक्स, देन 100 mg दे सकते हैं। ऐसे ही प्रीटोमैनिड का 200 mg टैबलेट जो वंस डेली है, लिनिजोलिड 600 mg टैबलेट जो वंस डेली है, एंड मॉक्सीफ्लॉक्स 400 mg टैबलेट वंस डेली है। देन उसके बाद में जो हमारा नेक्स्ट इंपॉर्टेंट पिलर है वो है प्रिवेंट। फॉर प्रिवेंशन ऑफ ट्रांसमिशन के लिए इसमें जो हम फॉलो करेंगे, एक तो है कोविड अप्रोप्रिएट बिहेवियर, लाइक वही हमें मास्क यूज में लेना है, प्रॉपर हैंड वॉशिंग यूज में लेनी है, 6 फीट डिस्टेंस मेंटेन करना है। इसके अलावा कॉन्टैक्ट ट्रेसिंग एंड टीबी प्रिवेंटिव बिहेवियर, जो रिमोट या ट्राइबल एरियाज है, डोर टू डोर जाकर के ऐसे लोग जो टीबी पेशेंट के साथ रह करके उन्हें केयर दे रहे हैं, वो भी मोर प्रॉन है टू गेट टीबी इन्फेक्शन, तो उनका हमें कॉन्टैक्ट ट्रेसिंग करना है। इसके अलावा एयरबोर्न इन्फेक्शन कंट्रोल इन कम्युनिटी, लोगों को एजुकेट करना है इस बारे में कि कैसे हम इसे प्रिवेंट कर सकते हैं। कम्युनिटी मोबिलाइजेशन, कम्युनिटी के पीपल को एक साथ में लेकर के प्रिवेंशन के लिए हमें ट्राई करना है। तो इसमें एक वर्ड आया है टीबी प्रिवेंटिव ट्रीटमेंट। टीबी प्रिवेंटिव ट्रीटमेंट के बारे में यदि हम देखते हैं तो ये है, इट कंसिस्ट ऑफ 1 और मोर एंटी ट्यूबरकुलस। टीबी को होने से रोकने के लिए हम एक या एक से 1 और मोर एंटी ट्यूबरकुलोसिस मेडिसिन यूज में लेते हैं फॉर प्रिवेंशन ऑफ टीबी। इसके अलावा कुछ और भी इसमें मेजर्स हैं, जैसे क्लोज कांटेक्ट अभी हमने पढ़ा, हैंड वॉश करना है, न्यूट्रिशनल डाइट है। तो मोस्ट जो टीबी की ट्रीटमेंट है उसके अंदर 2 ऑप्शन है। फर्स्ट है 3 मंथ वीकली आइसोनियाजाइड एंड रिफाम्पेंटिन एंड 6 मंथ डेली आइसोनियाजाइड। ये हम देते हैं कुछ हमारा जो टारगेट पॉपुलेशन है, ऐसे लोग जो कि इम्यूनो सप्रेसिव है, पीपल लिविंग विद एचआईवी। एचआईवी के केस में इम्यूनिटी लैक है तो मोर चांसेस है टू गेट इन्फेक्शन, टीबी इन्फेक्शन। इन्फेंट जो कि लेस देन 12 मंथ है एंड कॉन्टेक्ट विद एक्टिव टीबी। हाउस होल्ड, एचएससी मीन्स हाउस होल्ड केयर, जो कि इन लोगों के साथ में रहते हैं तो वो मोर प्रॉन है इन चीजों के लिए, तो उनको हम ये टीपीटी ट्रीटमेंट प्रोवाइड करते हैं। देन उसके बाद में हमारा लास्ट जो पिलर है वो है बिल्ड। बिल्ड जैसे कि आईसी, इंफॉर्मेशन, एजुकेशन, काउंसलिंग, कम्युनिकेशन, ये प्रोवाइड करना। इसके लिए हमारे बहुत सारे जैसे निश्चय पोषण योजना ये करके हैं, जो कि इसमें बिल्ड में इंपॉर्टेंट रोल प्ले करते हैं। मल्टी सेक्टोरियल कोलाबोरेशन, जिसमें ग्लोबल, नेशनल, लोकल लेवल पर लोगों को आपस में कोलाबोरेट करना है। प्रोक्यूरमेंट एंड सप्लाई चेन मैनेजमेंट, जिसके अंदर इंसेंटिव्स आ जाएगा, जिसके अंदर हम मनी या फूड बास्केट दे करके उन्हें सपोर्ट प्रोवाइड करते हैं। तो इसके बारे में यदि हम 1 बाय 1 देखें तो हमारा इसमें आ जाता है निश्चय। निश्चय करके एक वेब बेस्ड पेशेंट मैनेजमेंट सिस्टम है, जैसा कि इसका नाम है नी प्लस शय। नी मतलब एंड, शय मतलब कि टीबी, टीबी को एंड करने के लिए। जो मेन इसका काम है, इसमें जो भी केसेस है उसको हमें क्या करना है, रजिस्टर। जो टीबी केसेस हैं उन्हें हम रजिस्टर करते हैं, देन उसके बाद में उन्हें ऑर्डर दिया जाता है वो किस टाइप का डायग्नोस्टिक टेस्ट करेंगे, देन कौन सा लैब है उन्हें वो बताया जाता है, उनकी कंडीशन के अकॉर्डिंग ट्रीटमेंट डिटेल्स दिया जाता है, देन ट्रांसफर केसेस बिटवीन केयर प्रोवाइडर, मतलब जो नियर बाय उनका हॉस्पिटल है या फिर जो हेल्थ केयर्स है उसके बारे में उन्हें बताया जाता है। टीबी ट्रीटमेंट तभी स्टार्ट होगा जब आप निक्षय आईडी क्रिएट करेंगे, उसमें रजिस्टर्ड होंगे। देन निक्षय के बाद में एक हमारा है निक्षय पोषण योजना करके, जो कि 1 अप्रैल 2018 में स्टार्ट हुआ था। इसके अंदर 500 रुपीज पर मंथ जो टीबी पेशेंट है, ऐसे पेशेंट जिनका टीबी ट्रीटमेंट, एंटी टीबी ट्रीटमेंट चल रहा है, उन्हें 500 रुपीज पर मंथ दिया जाता है। या तो ये कैश फॉर्म में आता है या फिर इसके फूड बास्केट भी दिए जाते हैं। ये उन लोगों को दिया जाएगा जो कि निक्षय पोर्टल पर रजिस्टर्ड या नोटिफाइड है। देन 7 अक्टूबर 2024 को ये जो मनी है इसको डबल कर दिया गया फ्रॉम 500 to 1000 बाय द यूनियन हेल्थ मिनिस्ट्री के थ्रू। देन इसका जो मेन ऑब्जेक्टिव है कि हम बात करें निक्षय पोषण योजना क्यों जरूरी है, तो इसके अंदर जो हम फूड बास्केट या मनी दे रहे हैं वो क्या कर रहा है, इंप्रूविंग न्यूट्रिशनल स्टेटस। बिकॉज कोई भी डिजीज कंडीशन है उसका हम ट्रीटमेंट मेडिसिन देते हैं, लेकिन साथ में न्यूट्रिशन भी इंपॉर्टेंट है, तभी वो मेडिसिन इफेक्ट करेगा। देन इसके अलावा बेटर ट्रीटमेंट आउटकम, बिकॉज वो जल्दी ट्रीट होगा इसलिए। देन बेटर एडहेरेंस, लोग जो टीबी पेशेंट है उससे ज्यादा ज्वाइन करके रहें, अटैच रहें, इसलिए इंक्रीजिंग नोटिफिकेशन, लोगों को ये रहेगा कि हाँ हमें इंसेंटिव मिल रहा है या फूड बास्केट मिल रहे हैं, ज्यादा से ज्यादा लोग इसमें रजिस्टर्ड होंगे, अपने आप को नोटिफाई कराएंगे। रिड्यूसिंग आउट ऑफ पॉकेट एक्सपेंडिचर, जैसा कि हमने पहले पढ़ा, कैटास्ट्रॉफिक जो है उसको हमें कम करना है। कोई भी टीबी पेशेंट की जो फैमिलीज है उन पर कोई भी इकोनॉमिकली बर्डन नहीं होना चाहिए, उसको जीरो करना है, इसके लिए ये इसका मेन ऑब्जेक्टिव है। देन कुछ अदर डीबीटी स्कीम भी आती है अंडर एनटीईपी, जिसके अंदर इंसेंटिव बेनिफिशियल दिया जाता है, जैसे कि अभी हमने निक्षय पोषण योजना देखा, इसमें जो नोटिफिकेशन है उसके टाइम पर 3000 रुपीज, देन 3000 रुपीज आफ्टर 84 डेज, मीन्स पर मंथ 1000 रुपीज है। देन इसके अलावा कुछ ट्राइबल सपोर्ट स्कीम, जो ट्राइबल एरिया वाले पीपल हैं जो इसमें रजिस्टर्ड करवाते हैं, तो उनको 750 रुपीज एट द टाइम ऑफ नोटिफिकेशन दिया जाएगा। इसके अलावा सपोर्टर्स के लिए 1000 रुपीज फॉर डीएसटीबी, ड्रग सेंसिटिव टीबी के केसेस में 1000 रुपीज है, एंड 5000 रुपीज इन केस ऑफ ड्रग रेसिस्टेंट टीबी के केस में। इसके अलावा सपोर्टर्स में जैसे कि आशा वर्कर्स हैं, कम्युनिटी हेल्थ वॉलेंटियर्स हैं, उनके लिए भी इंसेंटिव में 250 रुपीज है। इसके अलावा इंसेंटिव फॉर इन्फॉर्मेंट्स की बात करें, इन्फॉर्मेंट कोई भी हो सकता है, कोई हॉस्पिटल है जो इसके बारे में इंफॉर्मेशन दे रहा है, क्लिनिक है, नर्सिंग होम है, लेबोरेटरीज है, या फिर सेल्फ रिपोर्टिंग बाय ए पेशेंट खुद के बारे में सेल्फ रिपोर्ट कर रहा है कि हाँ मुझे टीबी है, उसके लिए भी 500 रुपीज फॉर नोटिफिकेशन एंड 500 रुपीज फॉर आउटकम डिक्लेरेशन के लिए इंसेंटिव होता है। देन इसके अलावा निक्षय संपर्क करके है, जिसमें आउटगोइंग इनगोइंग सर्विस है, 7 AM to 11 PM तक इसका सर्विस है, 14 लैंग्वेज में है। इसमें किसी भी टाइप का हमारा काउंसलिंग है, किसी भी ट्रीटमेंट से रिलेटेड हमारा डाउट है, टीबी नोटिफिकेशन है, निक्षय पोषण योजना, सारा हम यहाँ से डिटेल ले सकते हैं। देन उसके बाद में नेक्स्ट प्रधानमंत्री टीबी मुक्त अभियान एक स्टार्ट हुआ था। इसके अंदर अभियान के अंदर निक्षय मित्रा करके एक अभियान चलाया गया है, जैसा कि इसका नाम है, निक्षय हमने पढ़ा था एंड ऑफ टीबी, मित्रा मतलब फ्रेंड। तो कोई भी पर्सन, कोई भी इंडिविजुअल, कोई भी ऑर्गेनाइजेशन, कोई भी रिप्रेजेंटेटिव कॉर्पोरेट एज ए निक्षय मित्रा बन करके टीबी पेशेंट की हेल्प कर सकता है। इसके बारे में हम थोड़ा सा डिटेल देखें तो 9 सितंबर 2020 को ये प्रधानमंत्री टीबी मुक्त भारत अभियान स्टार्ट हुआ था, जिसके अंदर कम्युनिटी पार्टिसिपेशन, कम्युनिटी के लोग ज्यादा इसमें ऐड हो, कम्युनिटी के लोग ज्यादा सपोर्ट करें टीबी पेशेंट को, उन्हें एक्सेप्ट करें, इसके लिए निक्षय मित्रा स्टार्ट हुआ, जिसके अंदर निक्षय मित्रा वही बन सकता है जो निक्षय प्लेटफॉर्म पर रजिस्टर्ड कराएगा। यदि हम इसके ड्यूरेशन की बात करते हैं तो ये मिनिमम 1 ईयर है और मैक्सिमम 3 ईयर है। ये 3 लेवल पर सपोर्ट प्रोवाइड करेगा, न्यूट्रिशनल सपोर्ट, एडिशनल डायग्नोस्टिक एंड वोकेशनल असिस्टेंस, किसके लिए, टीबी पेशेंट के लिए। देन उसके बाद में जो लास्ट हमारा आ जाता है इंडिया 100 डेज टीबी एलिमिनेशन कैंपेन जो अभी चल रहा है, जो स्टार्ट हुआ था 7 दिसंबर 2024 से। यूनियन मिनिस्ट्री ऑफ हेल्थ एंड फैमिली वेलफेयर श्री जगत प्रकाश नड्डा ने इसे लॉन्च किया था, जिस पंचकुला हरियाणा के अंदर। इसका जो मेन टारगेट है कि जो वनरेबल पॉपुलेशन है, ऐसा पॉपुलेशन जो कि मोर प्रॉन है टीबी होने के, जैसे कि अंडर नरिश्ड है, पीपल लिविंग विद HIV है, क्लोज कॉन्टेक्ट विद पीपल विद एक्टिव टीबी है, मतलब ऐसे लोग जो एक्टिव टीबी वाले पेशेंट का केयर कर रहे हैं तो उन्हें भी चांस है टीबी होने का। या फिर डायबिटीज वाले पेशेंट है, स्मोकर है, एल्कोहलिक्स है, इन लोगों को बहुत चांस है टीबी होने का, तो उनको डायग्नोसिस, उनका रिड्यूसिंग डायग्नोस्टिक डिले एंड एनहांसिंग ट्रीटमेंट आउटकम्स के लिए ये कैंपेन चलाया गया है। ओके, थैंक यू, बस इतना ही था।
It was really super presentation. I think she has covered each and every topic. And most of the nurses here might be feeling that this is a very new, this Yojanas and this Mitras and this Niksha is might be a new topic for them because they are not dealing with this TB. So I think we have gained much knowledge today. At even though her presentation was super, but I request Neeta ma'am to please can you put incorporate your expertise, ma'am, in this, and if she might have left any point if you think can add on.
First of all, congratulations, Indu. You have really presented very well. And she has covered almost all the topics that are under the program. So if there are any questions, we can take them, or we can go stepwise, how we go under the program. So if I don't see any questions in the chat box.
We have not started yet, no? Open up the session, then we will put the questions there.
ठीक है. ये screen share बंद करेंगे?
वो आ रहा है. What is stream at? अच्छा.
So let us go stepwise and we'll take your questions. First of all, this program was started in 1962 as National TB Program, NTP, which has been improved over the years. बहुत सारे नए initiatives इसमें जोड़ते गए to achieve our targets, because in spite of so much effort, उसका इफेक्ट जितना आना चाहिए उसको और बढ़ाने के लिए we have been adding newer initiatives and program has progressed. So from NTP it became RNTCP, from RNTCP now we call it NTEP, that is elimination program. Okay. So in the NTP or in our national program, we are using best possible technology to diagnose TB. In today's date and time, there is no investigation which is available globally and is not available in India. Okay, and all these diagnostic facilities are free of cost for each and every patient. And these are facilities like CBNAT, which can diagnose TB in 2 hours time. We have LPA, which takes 4 to 5 times. We have MIDGET, that is liquid culture. So there are a lot of technologies under the program depending upon the need of patient. There are mechanisms, how the sample will go to your DMCs or to higher centers or more higher. Then there is quality control of these tests happening. So once a program gives a report on TB or non-TB, it is quite reliable because there are quality controls at every step. And coming to tests which are available, we all know that microscopy has been the mainstay of TB diagnosis. जब भी हम TB की बात करते हैं तो हर एक कोई झील नेल्सन स्टेन की बात करता है ना? बट अब टाइम है अपफ्रंट नैट कराने का, मतलब कोशिश करनी है कि हम पेशेंट्स का CB नैट टेस्ट करवा सकें या ट्रू नैट टेस्ट करा सके. पॉइंट ऑफ केयर टेस्ट है कि सैंपल देके जितनी जल्दी हो सके हमें पता लग सके कि TB है या नहीं है. And then there is something called universal DST. मतलब हम at outset we try to find out कि patient को कहीं drug resistant TB तो नहीं है. जो हमारी main 4 दवाइयाँ हैं rifampicin, INH, pyrazinamide and ethambutol. इसमें से rifampicin and INH most important है. तो जो TB NAT है वो हमें 2 चीजें बताता है, whether there is TB or not and whether it is sensitive or resistant to rifampicin. So we should all try that patient को हम upfront NAT करवा सकें, ठीक है? That's the one of the mainstay of this 100-day program which Indu just told us about. So that is what we are trying. And then there are more sophisticated tests like line probe assay, which will tell us about more drugs, which is about INH, whether it is resistant to INH, fluoroquinolones, injectables. And then there are tests like liquid culture, which take more time and they're more sophisticated, and they tell you for about 13 drugs whether they are resistant or not. Okay. So this is all about diagnosis. I think we should take questions on diagnosis before we move ahead for treatment. So, Shiva, you can ask questions if they have about.
Thank you for bringing your expertise, ma'am.
I have one question, but I think first we can cover the chat questions.
We'll move on to the open house discussion. Anybody would like to ask any question on this
Okay.
topic?
So there is only one question. What is the procedure to register a patient? Okay. So
Dr.
once the
Meeta,
patient,
I would like to briefly address after
sure,
you finish.
sure, ma'am, please.
No, after you finish, please. आप बोलिए, please.
No, ma'am. I was just taking up a question which I can take later. We have just given them a little.
I just wanted to apprise all on the strategy for the 100 days campaign that we started. So maybe after you answer the question, Doctor.
Okay, okay, ma'am, as you say. So the first question that has come in, what is the procedure to register a patient in TB elimination program? So any patient who walks into our health facility will automatically get registered. Our health workers will register them on Nikshay portal. That is one. There is another facility, there is another app called Nikshay Sathi app, okay, which anybody can download. And they can also register themselves on that app and you can get a registration number. But once you go to our lab, our centers, our staff will register the patient and they will collect a sputum sample or get the X-ray done. Okay. Okay, so the next question is, ma'am, how do we decide that we need CB-NAT or midget? What are the indications for it? So CB-NAT is a genetic test which we try to do for all the patients. Okay, so midget comes much later when we want to see DST, that is drug sensitivity testing for more number of drugs. But CB-NAT is something that we try to do upfront. Even if it is not done upfront in some centers, the sample travels to the CB-NAT lab and CB-NAT is done for all diagnosed TB patients. Okay, right now we are trying to do it for anybody and everybody, but in routine it is being done for all the patients who report to our centers.
There is one more.
There were some initiatives in which injection BCG was given to adults as a preventive for healthcare workers. So, ma'am, kindly. Okay, so injection BCG is still under trial for adults. It is a study which has been taken in certain centers. So, CTD is still compiling the findings and we will get the final verdict from Central TB Division as and when it is decided.
Any more questions? You can put up in chat box.
So we have just discussed the diagnosis part. So we'll first take the questions on diagnosis and then we'll go to treatment. But over to Urvashi ma'am. Ma'am wants to make a comment.
So I will keep it as brief as possible, but I want all our attendees to understand the campaign that we initiated was with the idea of early diagnosis. So in case, so there is recent global evidence to tell us that we were missing cases, and there is evidence to tell us that the overt TB, the clinical TB that we identify, if we wait for cough to appear. So traditionally, the symptom that was being looked for in the community, you must have seen IC material that was available, would say 2 weeks cough. If the patient had 2 weeks cough, he should come forward. Now, what the recent evidence showed us was certain high-risk groups are more prone to having TB because their immune response is poor. Now, these high-risk groups, if I may list them out, are diabetics, people living with HIV, smokers, alcoholics, those who have had TB in the past, those who are older in age group, old age group, and those who have low BMI, that is BMI less than 18.5. Now, these patients may have, where they may not have overt symptoms, but they will have TB and they will be shedding TB bacteria in the environment, which like was covered very nicely in the first slide by our sister, that these droplets can dry up and become droplet nuclei, and in the community everybody can get infected. So during the campaign we made two major changes. One, we want to diagnose everybody early. Hence, we are going out, reaching out to all vulnerable populations to screen them with a handheld X-ray, which will be able to diagnose TB early. That is one effort that we changed from the past strategy. Another effort we did was enhance our symptom to 10 symptoms. Instead of 4 symptoms, now we're looking for 10 symptoms, including loss in weight. So the difference between, say, another disease that all of you are aware of, transmitted through air, and TB, is that the COVID would present, in an acute manner. There will be high grade fever, and the patient will straight away rush to the hospital, to the doctor, to understand what is a high grade. In TB, there is low grade fever. There is slow loss in weight. Slowly, the weight may be lost. The patient may ascribe it to something else. As it is, our population, the health seeking behavior is not good. This was again, brought out during the prevalence survey, that the patients do not approach the healthcare system for some reason or the other. So we are now trying to do active and rather intensified case finding, where we are reaching to the vulnerable groups. Also, the symptomatics in the community are being tested. So we are offering X-ray as a screening tool, followed by nucleic acid amplification test, which was discussed by Madam Singla also a little while ago. So NAT is a technology which is globally the current latest technology and has a very good detection limit. Hence, we use that as at the outset to get not only the detection of TB, but also detection of drug resistance. So symptoms I was talking about: low-grade fever, loss in weight, loss in appetite, and then the traditional ones that were talked, that, hemoptysis, chest pain. But we've also expanded this to include extrapulmonary TB. I'm not sure how much was covered on extrapulmonary TB. The idea of early diagnosis is that the patient, one advantage is that you diagnose them early and treat them early. So the comorbid conditions do not exacerbate, or the TB does not exacerbate due to, say, diabetes or HIV or other comorbidities. Two, these patients can then be treated early and they do not progress to extrapulmonary TB. So the mode of inhalation is the only mode of infection in the case of TB, but from lungs it could go to extrapulmonary sites and involve other organs. Also, if there's a delay in treatment, sometimes the patient can get MDR TB. If the patients, I notice a very good question by somebody who says adherence to drugs is very, very important. It is very important to do treatment completion. So awareness amongst the community and the nursing staff should encourage patients not to leave the treatment in between, because that could lead to sinister outcomes, bad outcomes. With these few words, I just wanted to summarize how the campaign was designed with this new strategy. And let me apprise you, we're covering about 455 districts of about 780 districts in the country. And we are picking almost double the number of cases, because now we're looking for early diagnosis of subclinical TB. So we would like all of you on board with this new strategy, and going forward, this will be the program strategy. So with this, thank you. And thank you, Dr. Neeta Singla, for allowing me to address them.
Yeah, thank you so much, ma'am. Hearing it from you is real delight, because it's like you have conceived the whole thing. So hearing from you is like hearing from the first person, which is really enlightening. Thank you so much. So,
Thank you, ma'am.
are there any questions on diagnosis? Anything?
Then we'll move to the chat box. There is one more question, I think. There were some initiative in which injection BCG was given to adults
Yeah,
as
I've
a
already
prevention for
answered that. Okay, so now let's talk about treatment. For treatment, first we have, as I said, there are two types of TB: drug sensitive TB and drug resistant TB. And drug resistant TB is initially diagnosed with the help of NAT testing or LPA testing or MIGIC testing. Okay, so it is always a lab test which tells you a patient is DRTB or not. Okay, no clinical examination can say that patient is a DRTB patient. It is a lab-based diagnosis. So coming to DSTB, we have very effective drugs today. Uh, Sister Indu has just told us about rifampicin, INH, pyrazinamide, and ethambutol as a treatment. The treatment is for 6 months. It's in two parts, intensive phase and continuation phase, and we give a fixed drug combination. All these drugs are available free of cost. Patient doesn't have to pay anything anywhere, and these are available in all of our dot centers. Okay, so a patient can just approach any health facility, can get enrolled, get diagnosed, and gets the treatment. So treatment looks something like this. The FDCs, as you see, there are tablets. This one tablet has all four. Yeah. So at the back, it looks like this. So every tablet has all the four drugs. Okay, so one tablet, it depends upon the weight, whether you need one tablet, two tablets, or three tablets. Okay, so depending on weight, a patient can take the medicine every day. This will help us for the adherence. Somebody asked, how do we, ensure adherence? So this is one of the way that we are trying to ensure adherence, that patient is taking all four drugs together, okay, and not taking one pill and leaving the another which he feels is not suiting him. So that's the intensive phase, and this is the continuation phase. It is same. It has three drugs, and that has four drugs. RHZE followed by RHE. Okay, and these should be given under somebody's supervision. Either it has to be some health worker, or if there is some patient lives in a condition where he is not able to approach any health facility, we have ASHA workers, we have Anganwadi workers who can, do the supervision. If nothing works, then we can try for family dots, where one of the family members can be a dot provider. We also have someone called TB champion, a cured TB patient who is ready to help others. Is a TB champion. So you can also involve the TB champions as the treatment supervisors, and there are mechanisms in the program where we can pay the TB champions or the workers who would help us as treatment supporters. Okay, so the most important part in the treatment is to have regular medicine in the doses that has been told to the patient, okay, and get the regular follow up. This is the best way you can treat a patient. As nurses, we should try to do the counseling. We can be the best counselors for adherence of treatment to the patient. So regular drugs in right doses and getting regular follow up. Okay, so that is the key to the treatment of the patient. And again, for DRTB, we'll not go too much in detail because it is very exhaustive, but we should know that there is something called H mono resistance, there is something called MDR, where you have resistance to rifampicin and INH, and then you have pre-XDR, where you have additional fluoroquinolone resistance, and then there is something called XDR, where along with pre-XDR, you have resistance to one of the group A drugs, which is bedaquiline or linezolid. Okay, so that will become too much of detail if I go into it. But if you have any specific question, you are most welcome to ask. We have treatment which is from 9 months to 18 months, which is shorter DRTB regimen and all oral longer. We discourage use of injectables because of its inconvenience and side effects also, but there are adverse events to all these drugs. So the thing is that we should be informed of this adverse drug reaction. We should do counseling, and we should try to recognize these adverse drug reaction as quickly as possible, and take the corrective step. Very new to DRTB is BPAL regimen with the, Dr. Urvashi Singh ma'am, our DDG, has just introduced this into our program, which is a 6 month DRTB regime. It is going to be implemented phase wise. We are still, scaling it up in some districts. So that's another regime which will now be available in India for all the DRTB patients. So that way I complete the treatment part and we can take the questions on.
Thank you, ma'am,
the
for
treatment
upgrading
plan.
all the nurses who are attending this, they and for the campaign also, campaign strategy
Yeah.
also. I think this was
So
very
I
new to
think
them.
ma'am has spoken very well about. But if there are, Shifa, are there any questions on?
I have one question on this CY.
Sure.
So I have one question on the this CY test, which Hindu have told.
पानी आप हो गया काम कट है
See how this have advantage over the Montex test because it's also injectable. It's also you have to read after 72 hours. Patient has to given patient will be have to come for 2 times. So what is the added benefit of this?
Of this, very good. That's a very nice question. So now we have been using Montu test right from the beginning. As when we started our career, we have been using Montu test. The CYTB test has come up new into the program. So first thing, the method of giving is same.
Introduction.
Method of reading is same. Okay.
Yeah.
So there is no difference in doing how you do this test. The main difference is between the specificity. The Montu test can come positive with any of the like we had BCG. So there were false positive and false negative test. Okay, but CY test is quite specific. It is using the protein which is specific to MTB and not to NTM or any other microbacteria. Okay, so it is using those antigens which are specific to TB, so they are same like IGRA. Okay, but for IGRA, you have to have blood sample, you have to go to a lab, get it done. So it is much easier compared to IGRA test, but its specificity is much better. But right now, we are giving the site-EB test only to people who are above 18 years. For right now, the Montu test has to continue for people below 18 years.
Are we implementing it in our program?
In our program, it is being now started giving. The supply has gone to most of the centers now.
Okay.
Now we move on to the next question. What is the procedure to register a patient in TB elimination program?
Yeah, so as I said, anybody who walks into our health facilities, they will get automatically registered, or they can register themselves on Nikshay Sathi app. Okay.
So I have one more question that is related to asymptomatic carriers. Now it's very much discussion on the asymptomatic carriers. So what is in our program's role or program's vision on this, that how we have to tackle this?
So asymptomatic carriers is same as latent TB, which Indu discussed very well. You know that how do we go about contact? So who can be the carriers? Carriers can be contacts of TB patients who are household contacts or close contacts at work conditions. So these people are called vulnerable population. People with low immunity, like diabetics, people, geriatric population, people who smoke. These are the people which is a vulnerable population and can carry infections. So for them, first and foremost is, to rule out TB. And then, to rule out TB, first thing you do is an X-ray or do a Cy-TB test. And then once you feel that if the Cy-TB test is positive, that means they are infected. They do not have the disease. So all these infected people should be given TB preventive treatment, which is in the form of either 3HP or 6H.
6H. Thank you. Thank you.
There is one more question.
Yeah, sure.
One more question. Ma'am, how do we decide whether treatment need TB NAT or midget?
Yeah, I've already answered that. So coming to our next page, where she talked is about build. So we spoke about diagnosis, we spoke about treatment, then we spoke about prevention. As ma'am asked about TB preventive treatment, now going to build that, how we are going to build our community to support our program. So we first and foremost is one of the things is differentiated TB care, where we should identify the patients who are more likely to be sick, so more likely to die of TB, you can say. So it is a patient-centric approach for tuberculosis that aims to reduce the mortality. And these are sick patients, patients with low BMI, patients who are malnourished, who are not able to stand, have tachycardia, have tachypnea. So all these patients should report to health facility, to hospitals, and should be admitted and taken care of to reduce mortality. So that is one of the initiatives that we are taking under the program. Then ma'am in very detail has told you about 100 days campaign. We are trying to accelerate the case detection by Jan Bhagidari. Jan Bhagidari is involving the people around us, taking their support. So they can be our ASHA workers, they can be our TB champions. Then we are involving corporates. These corporates are helping us in providing certain things in the program. Then we are doing Nikshay Shivir, where the mobile van is going to different places and offering X-ray.
Van का name?
Nikshay Shivir.
Shivir.
Shivir is a camp.
Yeah, I think
Shiver
this is also
in
a new
Hindi.
term.
Okay, Shivir
Shiver
is
means
a camp.
camp, no?
Shivir is a camp. So Nikshay Shivir are being held in different parts of the country in all these districts which are implementing 100 days campaign, and these vans are going to community and doing the X-ray, handheld X-ray there and then. And they also, some of the vans have the facility for collecting samples for CBNet. So that is, then we are going to different schools and colleges where we are creating awareness among children, among youth for about TB, spreading the message of TB, that they should understand, identify the people with symptoms and bring them to health center as quickly as possible. And as we said that we are expanding X-ray services and upfront NAT. So that is what we are doing in 100-day campaign. So that's how we are building up the facilities for the program.
Now, moving on to the next question, whether respiratory allergic patients
No,
are
it
prone to
doesn't.
TB.
It does not.
Please discuss common side effects and their management which can help in
That's a
adherence.
full one chapter. You need
Yeah, we will have in next session or somewhere that all the side effects related to
Yeah.
sensitive
But
allergic
it is
syndrome.
really necessary for all of us to be well informed about the adverse drug reactions, and recognize those reactions, and motivate patient to get to the health center as quickly as possible. So if I go, I'll just go in nutshell. With REFA, that all the secretions become red. So it's a adverse drug reaction, but doesn't require any intervention, just reassurance. So most of the side effects require reassurance at the outset. There can be diarrhea, gastritis, itching. All these things can be there with any drug. But if you go to specifics, then for every drug you have to know, and I think our next clinic would be on adverse drug reaction. So because we are short of time now, I will not. I can really go on with that.
We'll have a separate.
Sakshi Chaturvedi
Hello.
will have a great session on this.
Session on, yeah.
Hello.
Hello. Ranjana sister.
Good afternoon, ma'am.
Good afternoon. I was just thinking that there's no question today.
one small doubt. This Dikshay Mitra में जो हम पेशेंट की हेल्प करते हैं विद द मनी फॉर फूड बास्केट, तो पेशेंट को गवर्नमेंट की तरफ से भी पैसे मिलते हैं और फूड बास्केट भी, दोनों मिलता है या एक ही मिलेगा?
नहीं, दोनों चीजें मिलती हैं. जो गवर्नमेंट की तरफ से मिलता है, that's a money that goes directly to their banks. Whereas when you become Niksha Mitra, we give them food baskets. This is like differentiated TB care. We see ki kaun patient malnourished hai, who requires more. Because sometimes money that is going to the bank may not be directly used by the patient, once it goes to bank account. So we are just ensuring कि उसको nutrition मिल जाए. तो हम उसके लिए गवर्नमेंट ने एक norms दिए हैं कि एक फूड बास्केट में क्या क्या होना चाहिए. Adequate, there is protein, there is carbohydrate. They have made a full, there's a recommended food basket. I think Indu showed that picture, what should be there in the food basket. So that food basket is given to the patient irrespective of DBT. DBT every patient will get.
And the person who is helping as a Niksha Mitra, that person will, how he or she will know that patient has become okay and now he is not getting that basket? So that person can help other person.
So there is always a coordinator in every district with whom you can always find out what is happening to this patient. At least but in every district they are inviting all the Nikshay Mitras. A message is given that on this day we will be distributing the food basket. So people can come on that day and give the baskets themselves. But in case you cannot come, you can always get in touch with the coordinator to find out what is happening with your patient. So like you can help any amount, like 1 month, 2 months, but we recommend that you should help at least for 6 months. So after 6 months, you can always review whether the treatment has been extended for this patient, or you can do it for some other patient.
Okay, ma'am. Thank you so much.
Thank you for asking that question. I think your ma'am has made you crystal clear now, and you are being a part of this donation.
Yeah, so I would just request
Yes, yes.
everybody, they say कि अगर आप एक टीबी पेशेंट की मदद करते हैं तो it is like doing 100 यज्ञ. That's what they say in scriptures. That's what I hear. So yeah, we all should try to at least adopt one patient, be Nikshay Mitra to at least one patient and help them complete their treatment. Yes. And I really commend my nursing colleagues who have really adopted many patients. Most of us have,
Yeah.
I am one of the members, but that's why I wanted to ask.
Yeah, so we are very proud of it. मतलब हम बहुत गर्व से सबको कह सकते हैं कि our colleagues are helping us in all this. So thank you so much.
Any more questions? I know Zoom meetings can become silent, but if you ask questions, this session will be more.
So
Anita, quickly also, and tell them about the role of nutrition, or if you would like, I can speak.
Yeah, sure, ma'am. Please.
So, the role of nutrition has been proven from research studies. So there is scientific evidence that people, I told you about the group who's prone, 7 groups I talked about. Undernourished or low BMI patients is one such group where the likelihood of TB is more, and they can have asymptomatic TB, and that is why we were talking about early detection of subclinical TB. Now, there is a vicious cycle that undernutrition promotes TB, and if a person gets TB, he gets anorexia, he gets averse towards food, and may not consume adequate food, which will lead to undernutrition. So we at the program, I think there was a mention of Nikshay Poshan Yojana benefit. This was started in 2018, and in 2024 we enhanced the NPY support to double the amount, that is from 500 per month, now we're giving 2,000 rupees per month. This is basically just to support the nutrition of the patient so that the patient consumes protein-rich food and his immune system recovers. Also, the food enhances the drug absorption and hence facilitates cure. So, research studies have shown that patients who take care of their nutrition recover well, and also individuals in contact with patients, if they take care of their nutrition, they may not get TB. So these efforts again need to be, this knowledge needs to be given, communicated to the common man. So during your service, if you can kindly take this responsibility. The government also introduced something called as energy dense nutrition support for patients who are less than 18.5 to help them recover early and completely. And also, I don't know if you're all aware, in the November 2024, in our nutrition enhancement initiative, one, the NPY was doubled to 1,000 rupees per month throughout the treatment course. Second, the energy dense nutrition support was introduced only for patients who have BMI less than 18.5 for the initial 2 months, so that the recovery in the initial 2 months is the period when there is high chances of mortality. So we want to support them through the initial few months, and the drug absorption is better, they start recovering. And the Nikshay Mitra basket was enhanced to a bigger basket so that the family may also get good nutrition. So these 3 initiatives were laid down in November, and my request to all our nursing colleagues to disseminate this information. The NPY amount should be utilized for good protein-rich food, not necessarily, on expensive items, which, so by protein-rich, I mean those who take non-vegetarian can take non-vegetarian food. Those who take vegetarian can enhance their dal, milk products, and general other protein-rich food so that the immune system responds well. Thank you so much.
Thank you, ma'am. Any more questions? Any questions coming to anyone's mind? You can put in chat box if you don't want to ask separately.
There is one question: role of nurses in
NTEP.
NTP. See, role of nurses in TB, I can say. In NTP, as such in the program, I think at the grassroots, ASHAs, ANMs, community health officers, they are working for screening, for treatment, for prevention, for everything, for all the 4 steps of national strategic plan. And at the hospitals level, like our tertiary care hospitals where the patients with TB are admitted, then they take care of sick patients, and as well as TB prevention, cough etiquettes, and everything from starting from admission till the patient discharges. So the role of nurses is very, I should say, very crucial, starting from screening till the patient gets discharged. Whether it's in community, whether it's in hospitals, whether it's in schools, whether it's a health talk to general communities. So I think the nurse's role is very important in TB prevention and TB treatment.
Nurse's role cannot be finished in just 2 or 3 minutes. We'll have to take another session for this. Okay, any more questions? I think no more questions. We'll leave it, stop it here now. Ma'am, you have anything else to say?
I just want to thank you, and it's heartening to see such a good response. And
we have covered all the key points that we wanted to.
And this time it was very interactive. And ma'am, I think ma'am Neeta Singla, people ask so many questions.
No, it's really
I was planning
heartening
to just give them some incentive so that they ask questions, but I think of Neeta ma'am.
She was incentive.
Thank you so much. Thank you.
Thank you everyone for attending this session. I think all this link that you have received, you could join it easily. I hope that there's no issues this time.
And of course, we'll be doing more and more such sessions.
Yeah.
Because TB is our forte, and we all should be very well informed.
So have a great day ahead, and
the next this webinar will be 2 hours webinar, and it will be mainly on airborne infection control and prevention of TB, and it will be on 21st of March, ahead of the TB day, World TB Day. So I request all of you to join next month also.
We'll see you next month too. Goodbye. Before leaving, just give the feedback. You'll receive a link for the feedback. You just have to put your feedback on the chat box. We'll keep the session open for 2 minutes more so that you put your feedback.
Yeah. So my special thanks to Urvashi ma'am, who has taken such a keen interest in being with us and giving us the latest information. So we are highly obliged, and we look forward to your presence, ma'am. Thank you so much. I think nobody can put program in better words than you.
Yeah.
Thank you all, and I, like always, really compliment your efforts and initiative to continue teaching all our colleagues, whether it is doctors, whether it is nurses. And let me also thank the nursing colleagues. This is a very good initiative, and I hope more and more numbers can join in the future. There have been meetings where Dr. Neeta Singla has organized in the past where close to 1,000, 1,200 people have joined through the ECO platform. So the more the merrier, and we will all go together towards TB elimination. You can say with me, TB harega, desh jeetega.
Thank you, ma'am. Thank you,
And
Urvashi
today
ma'am.
we have included lab employees also.
So
that will be another wonderful thing. Yes. Another good idea.
From this month, we have included them also in our
ma'am,
session.
your presence itself is such a big incentive to be here. It really.
Thank you, madam.
Ma'am, I can't appreciate.
We're all in it together. TB elimination we cannot achieve. We have to work together.
Enthusiasm is very infectious, ma'am.
Thank you, ma'am. Thank you for sparing time for nurses program.
Thank you.
Thank you.